right, good morning everybody. It's February 16th. Gary and I are back. We have kind of a potpourri today, don't we? Kind of an update on a number of topics to keep you informed. A few things are changing. So let's go ahead and start off. I want to start with a congratulatory note, and that's this first slide, which came as a press release just recently from Sonoma County. This county is now 80% fully vaccinated. That's everybody over the age of 5. And the definition of fully vaccinated is a complete series, not the booster. But on top of that, 62% of people received a booster. So we're doing well in Sonoma County, 80%. That contrasts with the nation at 64% fully vaccinated, and the state of California at 69%. So we're kind of one of the leading counties.
Yeah, for the nation, 28% of people are boosted.
28%.
Yeah, so Sonoma County is really out there.
Big difference. So good work, everybody, because that's a small part for all of us. So let's look at how that reflects in our cases. The next slide, I apologize, it's not labeled as Sonoma County, but we have two graphs. One on the left is the positivity rate coming down nicely, just about 10%, and the new case rates. And remember, these are 7-day running averages, so there's a big lag because you can see it's dropping quickly. On the new cases, I want you to focus on that bottom right corner. We just talked about how well vaccinated you are, but you can see our case rate, even though it's a 7-day lag, is still not down to baseline by no means. And our next slide, which is a reflection of the data within the Sutter system. So this is reflective of the Bay Area. You can see the 7-day case average is almost down to our baseline. So still a fair difference in Sonoma County, despite our vaccination relative to some other counties in the area. And next slide is some recent changes in Sonoma County. This is timely. As of today, we have a masking update. You probably heard about it or read about it in the newspaper. But universal masking is no longer required with exceptions now. So it used to be universal. Now there are exceptions where it is required. And unvaccinated people, you'll see in this, are required to be masked in all indoor public spaces. Right. Of course, that's the honor system. But I do want to go through this list at the bottom of those areas where masks continue to be required for all. And that's public transit, the schools. You're aware that the state has not changed anything on the school. These are requirements from the CDPH, California Department of Public Health, mirrored by Sonoma County. Emergency shelters, healthcare settings, so that includes us. So nothing has changed for us. Our clinicians and our patients are still required to be masked indoors. Correction facilities, homeless shelters, and long-term care settings. So it's a great step forward. At least when you go out now, you have the option of revealing your mask. Obviously, you might still want to wear, but mostly the thing I wanted you to know is that in our clinics, nothing's changed. Right. Yeah. So, Gary, what's going on in the hospitals?
So in the hospital, things are still pretty busy. We're seeing a slightly tick down in our cases, but mainly unvaccinated people are coming in hospitalized. We still have some young people as well. About 6% of our swabs in the hospital are turning positive, which is much less than the 25% that we saw just a few weeks ago. I'll show you an interesting slide I got from the New York Times. And this shows that for unvaccinated people, hospitalization rates are still going up. But for vaccinated people and boosted people, hospitalizations are going down. So overall, in the United States, hospitalization rates are going down, but in the unvaccinated cohort, people are still getting vaccinated at very high rates. So again, the message is, it is a very dangerous thing to be unvaccinated during the pandemic. Whether it was the Delta surge or the Omicron surge or whatever's coming down the pipe, it's still a very dangerous thing to do.
Okay. Well, let's talk about vaccines, because there's been some movement on that recently. So what's the latest on vaccines?
So there's been a little news with the FDA. So on February 11th, the FDA, which is going to fast track the Pfizer vaccine for kids 6 months to 4 years of age, they retracted that. And I wanted to let everyone know kind of what happened with the FDA. So initially, it was a 2-dose series for kids aged 6 months to 4 years. And when the data was being collected, it was being collected more in the Omicron surge than in the previous Delta or other surge. And it found that kids 2 years to 4 years of age only had a 60% antibody levels versus the teenage study, Two reasons for that. One, the Omicron variant, it's a little bit, the neutralizing antibody levels, it gets around the virus, around the vaccine a little better. But also in this age group, in 6 months to 4 years, the dose is 1/10. It's 1/10 of the dose as we were using in the teenage group, so less antigen, and also during the Omicron surge. So what Pfizer said is, well, we want to suggest a 3-dose vaccine series. And the FDA said, if you want to approve this as a 3-dose vaccine series for children, we need to see the data, and that delayed it. So right now, we don't know if 6 months to 2 years is going to be a 2 or a 3 vaccine dose, probably 3 vaccine dose. We probably won't see that for another month. So I think the FDA stalled that for all the right reasons. Clearly, you can understand why Pfizer want to get the vaccine out there, how much money they make in 18 million doses in the US, because that's a cohort of those kids.
Makes you wonder if the 1/10 dose was the right decision, which was probably made some time ago.
Right, and the 1/10 dose is based on a lot of reasons, but also you don't want to see any adverse events. And there were no serious adverse events in the study, but you're right, maybe that dose was too low.
On that side.
Right. Yeah. Now, what I did put together for everyone, and I think this is helpful, and I want to thank, this comes from Jeff Silvers. So Jeff Silvers gave a great talk on this, and this vaccine table was presented by him. So these are kind of the vaccines for healthy and immunocompromised people. It gives the years for which you want to get the vaccine, like Pfizer from 5 to 11 years. The second dose is at 21 days. It's not approved for a booster yet in 5 to 11-year-olds. But for the Pfizer for 12 to 17-year-olds, again, you give the second dose at 21 days and a booster at over 5 months. In the immunocompromised things have changed a little bit. So in the immunocompromised patients, we're giving Pfizer and Moderna vaccine boosters, so the 3rd dose and now a 4th dose. And so the 3rd dose can be within 28 days of the previous dose, and then the 4th dose for immunocompromised folks can be in less than 3 months. And the reason is we know in the immunocompromised patients, your antibody levels fall a little bit faster. And so you want to get them in for that 4th dose. And I think you mentioned earlier, Gary, that kind of came around without a lot of fanfare. And I think that we're being a little bit more aggressive with that with like our oncology patients. I've certainly been giving a lot of 4th doses to my HIV patients. But it's clearly an immunocompromised patient. You want to make sure that they get that 4th dose to have that much reassurance.
Part of the confusion is the nomenclature, because we called the 3rd dose the booster dose.
Right.
And now the table says the booster dose after the 3rd dose, so it's challenging. It's probably easier to call it the 4th dose.
Yeah, I ask patients, have you got your 3rd dose? Have you got your 4th dose?
Yeah.
You know, and I kind of leave out that boosting thing, because you're right, there is some confusion around it. But hopefully, hold on to this table, and if you want to, I'll email this to everyone. It's a good summary if you just want to know what ages, what's the time frame, which ones are approved, which ones are not approved for that 3rd and 4th dose.
Good.
One more thing I want to share, and this is all good news, is recently an MMWR came out just on February 15th, so yesterday this came out, showing vaccine effectiveness in pregnancy. And so there was an earlier study showing that SARS-CoV-2 actually has some pathogenic effects in the placenta, that its properties, its pathogenicity starves the fetus of oxygen, which causes a lot of stillbirths. And the good news is vaccine is very effective and safe in pregnant mothers, but if you give the vaccine after 21 weeks of gestation, it's 80% effective. So you want to give it later on in the pregnancy if you can. And in the study by the MMWR, infants 6 months of age of less born to mothers who completed the vaccine series were 61% less likely to be hospitalized. And that's good information that it not only protects mom, but it also protects their infants.
And I know this is a big study, right? I mean, this is in 20 hospitals, and I think, what did I read, 176 infants hospitalized with COVID.
That's right. Yeah, so 176 kids hospitalized, 84% of those kids were born to mothers who were not vaccinated. Wow. So clearly there's a good response to vaccinating a pregnant woman. It's not 100%, and no vaccine is, but it's very effective and very safe.
So that's good information for OBGYN. More data to support your recommendations for vaccines among your pregnant patients. So let's switch topics and just kind of review what our treatment options are. It seems to change periodically.
So the news on the front is that there's a new monoclonal antibody available for early treatment. So this is an ambulatory treatment. It's called bevacizumab. So I put this table together for everyone just to kind of summarize and put in this new monoclonal antibody. So in the ambulatory setting, we have molnupiravir, And you want to use that in patients who are less than 5 to 7 days symptomatic. Paxlovid is the other antiviral that's available, 800 milligrams BID for 5 days. Again, less than 5 to 7 days of symptoms. And the two monoclonal antibodies, sotrovimab is IV, and this new one, bemtevimab, has good activity against the Omicron strain. It's a one-dose infusion, and we don't have it yet, but it should be coming soon through public health. And then I put at the very bottom here, those are the treatment monoclonal antibodies. The prophylactic monoclonal antibody, Evusheld, which is 2 monoclonal antibodies, is not for treatment, it's for prevention if someone is not responding to vaccine, like the immunosuppressed, or post-exposure prophylaxis in the immunosuppressed. And Evusheld is an IM injection. We actually have it now available in the oncology center, so oncologists are starting to use it more.
So that is available now?
Yeah, we have
Okay.
Evusheld. It's the hospital gets it, and it's Carolyn Dam, who is the hospital manager, also manages the infusion center, so she has access to the infusion center in the oncology building.
And the IV monoclonal antibodies are still given in the emergency room?
Right, so sotrovimab is still given in the ER, and bemtevimab will probably follow the same.
Okay, right, good. And then, something we don't talk about very much, but the flu.
Yeah, Gary and I thought it would be good just to kind of switch gears a little bit, because not everything URI and pneumonia is COVID. And so we just to let you know that the influenza season has been sort of percolating and kind of smoldering underneath our feet. And this is data recently out from the CDC showing a map of the US. And it shows that in most of the US, influenza was minimally to moderate at most, except for New Mexico. And the levels are coming down into much lower to minimal range. And then if you look to the right, I've included some data from CDPH. This is state data that shows that most of influenza this year was influenza A, but week by week, our numbers are going down. So I think the influenza season percolated underneath our feet. Now it's going down. RSV also seems to be going down. And I really think those are the public health measures. And it'll be interesting to see if we see a bump in anything, RSV, para-influenza, as we loosen the restriction on masks. I suspect that'll happen.
It also makes me wonder if masks will become a more broadly applied preventative measure in future years. Let's say we are in November, December, start to see a big influenza year.
Right.
If public health says we're now recommending masks.
Well, you know,
it seems to be effective.
I spent a lot of time in the emergency department, and I'll tell you, a lot of the ER docs are like, masks are going to be the new meat, because they're not getting sick. They're not coming home with a viral illness.
Yeah.
They're not coming home with influenza.
Yeah.
And so I think in the ER setting, especially when it's really tight quarters, and in some clinical settings, I'm going to be supportive of that.
Yeah.
I think it makes a lot of sense. And then, like, for example, if someone's traveling with medical problems on a plane, maybe that's the new norm, simply to wear a mask. Maybe not an N95, but to be careful about hand hygiene and to wear a mask.
Yeah, time will tell.
Yeah.
Great. Thanks for all those updates. Last thing is just a reminder that the booster mandate per CDPH on March 1st, all of us have to have our booster. Still have a handful of you out there who either have not received a booster or have not notified us that you have received it. So you got an email or a text rather from Erica yesterday and just asked you to please respond so we can complete our roster. So that's all we have today. Beautiful day as things are starting to open up from the drop in COVID. Hopefully everybody can get out and enjoy Sonoma County. Think of like what it was like 2 years ago.
Yeah, and just a little shout out. I want to say happy birthday, Mom. My mom turned 90 a couple of weeks ago.
All right.
And so I just want to say, and thank goodness she's boosted. So thanks for everyone.